It's a very great pleasure for me to be here and talking to you about this topic, which is very close to my heart today. If I could be a bit less PR-y about it, I would have titled this Ultraviolet Radiation and Cancer, It Might Be More Than Skin Deep. I'm going to give you a lot of information and no actual facts today, so you're going to go home going, well, now I don't know what to do, so we'll see how we go at the end. So before talking about the potential good side of the sun, I want to talk about the bad and the ugly. Neville Owen put it really well when he said melanoma writes its message in the skin with its own ink and is there for all of us to see. This is the bad of ultraviolet radiation exposure, and the ugly is that 1,500 Australians lose their lives from melanoma every year. So we certainly can't estimate the bad of the sun's ultraviolet exposure. And in fact, very interesting publication by Max Parkin from the UK in 2011 showed that if we were able to take our sun protection habits back to the way we were in the early 1900s, when having beautiful white skin was considered to be a mark of wealth and being important in society, back then people tried to protect themselves a lot. And if we could go back to that, in the UK they would have prevented 86% of all melanoma cases that occurred in 2010. My group at QIMR, colleagues there, we're working on a similar estimate for Australia, and unfortunately I'm not able to release that to you, but I can tell you that if we went back to protecting our skin the way we did many years ago, we would be preventing a lot of melanomas in Australia as well. And it's not just melanoma. The ugly-looking picture there is a basal cell carcinoma. The keratinocyte cancers, or non-melanoma skin cancers, affect about 500,000 people in Australia each year, and many of us get more than one. I'm sure many of you have had them. I've had 2 basal cell carcinomas, the first when I was 29. So these things we tend to think of as pretty benign. We go to the doctor, they chop them off and they don't cause us much trouble, but they can become extremely nasty, particularly on the face. The big issue, though, is that it's estimated that next year we will spend $700 million a year of our health budget on managing these skin cancers, and that's an enormous burden to our health system. So it's really important that when we talk about the potential good of sun exposure, we do not forget the bad. As a result of our knowledge about that, we've had about 30 years of health promotion with the Slip Slop Slap message in various different guises. From Slip Slop Slap, we've had Slip Slop Slap and Rap, we've had Slip Slop Slap Seek and Slide, try saying that fast. And in fact, this jingle here was one that I remember really well. It must have been around when I was a late teenager that I've put on the screen there. I could actually sing it for you, but you'd probably all go home. But I'm sure many of you would actually remember the tune. And if you want to know the tune, come down and I'll sing it to you privately afterwards. I'm going to do it. And the message has been very effective. This photo was taken of, it's actually a colleague's twins in the late 1990s, showing the way that we now protect our children from the sun. Unheard of when I was growing up and on the beach in the 1970s. We now have, we see kids on the beach dressed in sort of neck to knee sun suits. The sun protection message has been very effective, and we need to maintain that message. And this is where we see the effect. This chart shows the annual percent change in the SEC and BCC in the last decade or so. And I'll just get my pointer working. You see that in the people who have been exposed to the sun protection message, so sort of our 15 to 24-year-olds and younger, or even 35 to 44, really starting to be exposed to this message when they were children. We're now starting to see that the rate of increase, instead of it being an increasing incidence each year, it's actually falling. So the annual percent change is dropping in those younger populations that have been exposed to the skin cancer message as children, whereas those people who are older, who've had decades of sun exposure before that message kicked in, are still experiencing a year-on-year increase in the incidence of these non-melanoma skin cancers. So we can see that this is for the non-melanomas, and we can see that we're seeing the benefit of the Slip Slop Slap message. We're also seeing it in the younger cohorts for melanoma, although I don't have the data here to show you. So I thought I should start with that to emphasise that I'm well aware of that, and we need to maintain that message. But we're now starting to see perhaps there's some potential for benefit in the sun exposure, that the sun has a good side as well as a bad side. And really one of the earliest indications that this might happen, and you have to use a bit of an eye of faith here, I think, was some work looking at the incidence of different, well, this is mortality, but incidence as well, of cancer in different US states. And the red colour shows high incidence. The sort of salmony pinky colours are the next highest, and then down to the dark blue is which is the lowest. And you can see for prostate cancer that the states that are further away from the equator and therefore have got lower levels of UV have higher rates of prostate cancer. For these other cancers shown here, which people still talk about this being a trend, yeah, maybe. I'm not quite as convinced. But certainly this was part of the early hypothesis-generating data to suggest that perhaps UV exposure might be important. But obviously there are all sorts of other differences between these states as well. The southern states in the US have had much faster increases in obesity, for example. So we've had all sorts of differences in the way that things have happened in the US. So we need to be a bit careful about how we interpret that. This is another indication. This shows breast cancer rates by latitude. We see a similar figure reported in the literature for lots of other cancers as well. And what this shows is here's the latitude, here's the equator. And as we move away from the equator, either north or south, we see increasing rates of, in this case, breast cancer, but also other cancers as well. And again, that's been suggested to be due to ultraviolet radiation, which is higher near the equator than it is further away from the equator. But I would just like to point out that all these countries that are sitting close to the equator, countries like Papua New Guinea, Solomon Islands, lots of those countries potentially have got less good registration of their cancers and many other differences as well in things like diet. So I don't think that we can actually say, well, this is definitely due to ultraviolet radiation. There are too many other things going on. But nevertheless, this has been the sort of data that people have been using to say, well, we believe that the sun exposure might be good for us. If, however, we take a look at, this shows countries like Australia, New Zealand, the United Kingdom and Norway, Denmark and Sweden, where we'd expect cancer registration to be pretty similar. And we see what we'd expect to see for melanoma, that Australia and New Zealand have much higher rates than our counterparts in the Northern Hemisphere. But we see this trend going the same direction for colon, lung and prostate in men and breast in women. So this completely contradicts what I've just shown you, that suggests that us, with our higher levels of ultraviolet radiation, have actually got higher rates of colon cancer than countries with lower. So it goes against what lots of people are saying we're seeing in ecological data. I'm going to show you some Australian data. This is some of my own work that shows the risks of developing pancreatic cancer in the eastern states of Australia. Sorry, Western Australians. I'm an Eastern Australian person. But we get a nice latitude gradient across the 4 eastern states in Australia. So comparing to Queensland, which we've set as our reference category, we see that there's about an 11 to 13% increased risk of getting pancreatic cancer if you live in New South Wales or Victoria. Drops off a little bit in Tasmania, but with very high error bars because of the smaller population in Tasmania. So you can see that perhaps as we move further away from the equator and have lower UV exposure, we have a higher rate of pancreatic cancer, but that is also potentially explainable away with other things. So what I've been just showing you is data on whole populations, ecological studies, good for generating hypotheses, but we need to be really careful about drawing conclusions on the basis of studies of whole populations because we don't have measurements at the individual level. So these sort of population studies are interesting, but we need to move beyond that. So here's some data where we do have measures from individuals, and it shows that as the ambient residential exposure goes up in this population of people that entered a cohort, it's about 500,000 people, entered a cohort and answered questionnaires about where they lived and also about things like smoking and diet and all those other things that can influence risk. And you see that what we expect to see, that as ambient UV goes up, melanoma goes up, but we see some falling rates of some other cancers here, colon, lymphoma, but then we see some U-shaped curves for things like thyroid cancer and pancreatic cancer, which is the one that I'm most interested in. We see that as UV goes up, risk of pancreatic cancer goes down, but then as it keeps going up, the risk goes back up again. There's not a picture, but we see that there's protective effect of UV for prostate, but absolutely nothing going on for breast cancer. So I'm now going to tell you a tale of 3 case control studies that have conducted in the past over at the QIMR Berghofer Medical Research Institute. One in pancreatic cancer, which I was the lead investigator of, one in esophageal cancer, and one in ovarian cancer with David Whiteman and Penny Webb as the lead investigators. So in each of these case control studies, we recruited people with and without the relevant cancer, and in addition to asking them about lots of other lifestyle factors, we asked them where they'd lived throughout their whole lives. And then we spent a long time looking up the postcodes for all of those locations and assigning those postcodes to a latitude and longitude grid so that we could use satellite data from NASA to assign a UVR to each spot. And then we calculated a UVR score for each person, depending on where they'd lived. So the important thing is we didn't ask them about their behaviour, how long they'd spent in the sun, but we did look at where they lived. And we know that that's one of the most important factors that drives our risk of skin cancer. So it stands to reason people who live in higher ambient UV areas have higher exposure. So before launching into the results, I just sort of should tell you I have a pancreas. I study pancreatic cancer and I talk to patients with pancreatic cancer all the time. And I often hear from them, well, actually, I didn't even know I had a pancreas. So I thought I would just let you know that you do all have a pancreas. It sits up in the upper part of your abdomen, tucked in behind your stomach. One of the reasons that pancreatic cancer has very nasty outcomes is because it just causes a bit of grumbly tummy pain. When something goes wrong with it, we don't know about it very early, and it's actually very difficult to get a good look at with our standard imaging techniques. So pancreatic cancer is actually the 10th most common cancer in Australian men and also in Australian women. This is the male chart, but if you replace prostate with breast, you get the female chart. It looks very similar. So you can see pancreatic cancer is relatively rare, but it's the 4th most common cause of cancer death in Australia. The 5-year survival is about 3%, so only about 3% of people who are diagnosed with pancreatic cancer are alive 5 years later. And in fact, 50% of people are dead within 6 months. So it's really important that we understand what causes pancreatic cancer, because then we can do 2 things. One is we can potentially prevent it, and the other is we may be able to find a population that is at sufficiently high risk to warrant screening. So here's the results. This shows that when we gave people their ambient UV score, this shows at birth that we see as the ambient UV of a place where people lived increased, the risk of developing pancreatic cancer went down. Out here, very wide error bars because there weren't all that many people living in these very high UV areas. This is the sort of UV you get living in Townsville, Cairns sort of areas. When we look at exposure over the whole adulthood and we split their UV score into 4, we see people who lived in a high UV area were at about a 40% reduced risk of developing pancreatic cancer than those people who lived in the very low area, and this sort of obvious trend going down as UV score increased. So there's certainly some evidence for our own data, even after we adjusted for a whole heap of other lifestyle factors that might be related to where people lived. We saw this protective effect of UV for pancreatic cancer. Showing you now the esophageal cancer results. Here's your esophagus. And there's 2 different types of esophageal cancer. One is squamous cell carcinoma, which occurs in the upper part of the esophagus and is very much driven by alcohol and smoking. So less amenable to other things influencing it because it's so strongly influenced by smoking in particular. The other type is adenocarcinoma, which occurs in the lower part, I can't make my pointer work very well, lower part of the esophagus. And you'll see, when I show you in a tick, that adenocarcinoma has been increasing very rapidly. So here's this is the rate compared to the rate in 1975. So this is not saying that esophageal cancer is higher rates than melanoma or prostate cancer, just that it's been the fastest increase in cancer since 1975. So there's been about a 6-fold greater number of esophageal cancers in 2000 than there were in 1975, an enormous increase. But if you break that down, the increase is actually only for the adenocarcinomas, whereas in fact the squamous cell carcinomas have been dropping a bit. So this increase in the adenos is almost certainly largely a result of increasing BMI in the population. But here's the results for sun exposure. So this is lifetime. So this is daily average UV over a person's lifetime. And for adenocarcinoma, compared to people with who lived in areas with very low UV, those people who lived in a medium area had a 62% risk and about a halving of the risk in the people with very high UV areas. What's interesting about this is that we don't see it for esophageal squamous cell carcinoma, which I said was really strongly driven by smoking. And this gives us some confidence in our results, because whenever we see something just happening everywhere, we go, well, there's some weird bias in the way that our data set has been collected. But the fact that we see it for one type of esophageal cancer and not for the other gives us a bit more confidence that this protective effect might actually be real. And finally, ovarian cancer. Just again to show you the data, this is a slide that I stole from my colleague Penny Webb, and so it shows a number of different gynaecological cancers on it. But here's ovarian cancer. There's been a small increase in the numbers that occur each year. About 1,500 women affected each year with ovarian cancer in Australia, and a very poor survival of 43% 5-year survival. So it's another really nasty cancer. The three we're looking at are all pretty nasty. And here's the sun exposure data. This is lifetime ambient UVR. And again, with ovarian cancer, we see that as the UV went up, the risk of ovarian cancer came down. And in fact, there's about a 30% reduction in risk in the highest levels compared with the lowest levels of ovarian cancer, of sun exposure, sorry. So there's the data, some data showing you about associations between UV and developing cancer. But is it possible that the sun could help people with cancer to survive? Well, it's a very difficult thing to get a handle on. There's been lots of research looking at season of diagnosis and how that might influence survival. And interestingly, a lot of studies from Norway, there's something they're really interested in, but a number from other countries in the Northern Hemisphere as well. And they mostly show the same thing, that there's a reduction in the risk of dying if you're diagnosed in summer or autumn versus winter or spring. And I have to say, I don't quite get that, because diagnosis is a point in the pathway, and it might be actually that the sun exposure quite some time before that, when the cells were losing control, was much more important. So diagnosis is just a single point in the pathway, and it's different in everybody's pathway. So I don't quite understand how to interpret these results, but nevertheless, this is being used to suggest that high levels of sun exposure, when you get diagnosed, reduces your risk of dying from a number of different cancers. But all that work that's been done on season has been predominantly done in the Northern Hemisphere, and here's some results from Australia, published by Bruce Armstrong last year, and it shows the opposite for prostate cancer. So here's where people live, ambient UVR, and this is showing the relative excess risk of death. So compared to people who live in low UVR areas, people who live in high UVR areas are more likely to die from prostate cancer. And with season, compared to, here's our reference, if you're diagnosed in winter, you're more likely to die if you're diagnosed in summer or autumn. So we see the opposite here in Australia to what is seen in the Northern Hemisphere. I told you I was just going to tell you what we don't know. So I think in the Northern Hemisphere there's a lot that goes on with season that we don't see so much in Australia, and one of those things is a really important effect on behaviour. So people who are diagnosed in summer, when the days are longer, they feel a bit better, they can get out and exercise, they're potentially more likely to complete their early treatment. I think that's potentially got an effect as much as sun exposure on survival, and we don't quite have the same thing happening in Australia. So as to how to interpret this opposite effect, the answer is I don't know. So what do we think we know? Studies of whole populations suggest lower rates of cancer in areas with higher ambient UVR. Is it sun? Yes, possibly. There are some studies with measurements of individual participants, including our own studies, which support those findings, and really it's pretty unclear whether or not UV influences survival. But if there is an association with the sun, what's underpinning that? Well, one possibility is it's vitamin D, and I'm sure you've all heard a lot about vitamin D lately, because sort of in the media every second week almost some story about vitamin D and what it does for us. So just to quickly talk you through vitamin D physiology, the UVB from the sun, which also causes skin cancer, acts on our skin to produce pre-vitamin D and then vitamin D that then is carried in our bloodstream to our liver, or alternatively we can get vitamin D through a small number of dietary sources, exactly the same thing, also travels through our bloodstream to our liver, where it undergoes a step to convert it to 25-hydroxy-D, and I'll just call it 25D. It's the intermediate, relatively inactive marker of vitamin D, but it's what we measure to determine people's vitamin D status. It has to undergo another conversion step, mostly in the kidney, but also in some other cells as well, that then has effects on a number of different organs. We know it's really important for calcium absorption and for maintaining our bone health, but it also has actions on the immune cells, and also we know from studies in the lab that it has important effects that might reduce cancer. So it inhibits proliferation, for example, so it stops cells from dividing too fast. I like showing this slide. I got spammed by a company that sells makeup products. I don't know if they'd seen a picture of me or something and they thought I might need some help. But anyway, they were trying to sell me mascara, and as part of that it was supporting breast cancer. They were giving money to breast cancer. But the thing that I really noticed on this slide was this breast cancer tip: take your vitamin D every day. It's been clinically proven to lower your chance of getting breast cancer. So there are certainly some believers in the vitamin D story out there, and I actually sent them back an email saying, would you mind defining clinical proof for me? And they didn't respond. So I'll show you what the clinical proof is for breast cancer. So I'm just going to have to take a minute talking you through this slide because there's a few complexities on it. So I'll start by telling you what we mean by prospective studies. This is like what I described before, where we recruit a whole pile of people into a study, just people like you and I generally. Sometimes it's people with a particular disease, but the studies I'm talking about now is predominantly just general population people get recruited into a study and they give a blood sample, and they usually answer a questionnaire that gives us information about lots of other risk factors for disease. We follow them forward in time to look at who gets cancer and who doesn't, and then we relate that back to what their vitamin D levels were when they first entered the study. So that's a prospective study. Meta-analysis, we're pulling together all the different studies around the world that have been done to come up with a single estimate of effect of what vitamin D does. So this is looking at the highest versus the lowest category of circulating 25D, that marker in the blood. And the dots are the estimate, the relative risk, so the risk in the high category versus the risk in the low category. And if the dot falls on this one line, it means there's no association. The lines tell us the error around that estimate of effect, around that risk. So what we see is that for breast, as opposed to there being clinical proof, there's actually no association at all with the risk of developing breast cancer. From this meta-analysis that Philippe Portier included in his review, I've lifted all this data from a review by Philippe Portier, we see no association with prostate cancer. The one cancer where there is consistent evidence of a protective effect is colorectal cancer. Pancreatic cancer, the one I'm interested in, is a really interesting story because this meta-analysis showed a strong increased risk of pancreatic cancer in people who had high vitamin D levels, and that's the only one that Philippe included in his review. Actually, there's been another pooled analysis where people put all their data together and showed a protective effect. So we don't know, really. We need more work on pancreatic cancer to try and understand what vitamin D might be doing. But Philippe left out a couple of meta-analyses. This one is interesting. This shows all individual studies that have been done on 25D and prostate cancer, and it actually shows some hint of an increased risk, a 4% increased risk, although not quite statistically significant, in people with higher levels of 25D in their blood than lower for prostate cancer. And in fact, we're starting to see a number of U-shaped curves appearing where people with really high levels of vitamin D are at increased risk of prostate cancer. There's a sort of optimal level in the middle. Looking at vitamin D and cancer survival, this shows the relative risk in the highest versus the lowest 25D at the time people are diagnosed with their breast cancer. With their cancer in general. So the red ones are statistically significant, and the others are not. But you can see that for every single one of these cancers, the direction is in the direction of a protective effect, a reduced risk in people with high levels of vitamin D than with low. But what I want to point out is that sick people, really sick people, are lying around in bed, they're in hospital, they're not out in the sun making vitamin D, and they're more likely to die. So we try and adjust for that in our analysis, but it's pretty hard to adjust for I feel lousy and I'm staying in bed. We try, but it's very difficult. So we really, really need clinical trials to help us understand this data. Penny Webb and I at QIMR have got a paper under review at the moment showing a strong protective effect for ovarian cancer survival, actually, and we're wondering about doing a trial to try and understand whether or not this is really important, because we do see this strong association with people with high levels of vitamin D at the point of diagnosis having a reduced death from ovarian cancer. And I'm not showing you the data because it's not yet published, but we're seeing it for that really high-risk cancer as well. This is a spaghetti junction. This shows you the problem that we face in these types of prospective studies. This is what we want to understand. We want to understand how vitamin D level influences cancer risk or survival. And this is drawn for risk. This is a nice package we have to help us know how to analyse data. It's called DAGgerty because it draws a DAG, which stands for Directed Acyclic Graph. And what we do is we draw in all the things that we know about. So I've just got a few of them on here. So it shows that we know exercise is associated with vitamin D levels. We know that exercise is associated with cancer risk. We know that BMI, exercise influences BMI and through that influences cancer, but it also influences vitamin D levels. So by the time we put all these in, and this isn't all of the things I could have put in there, we have this major spaghetti that we have to try and work out, well, what's the association here, given all these other things that are potentially influencing the association? We have to try and adjust it out. It's very difficult. And particularly when I put this into DAGgerty, it said to me, well, you really have got to adjust for exercise and diet. So who can tell me what they ate last week? Anyone? No. Diet's incredibly difficult to measure. And our adjustment is only as good as our measurement. So if we can't measure diet properly, then we can't adjust for it properly, which means that any association we see between vitamin D level and cancer might be simply because we know that diet influences both vitamin D level and cancer. Very difficult. So this is where we need trials. So the way we get around it is that we basically toss a coin to decide who gets to take a vitamin D supplement and who takes a placebo. And by doing that, what we do... Lost my pointer again. Anyone see it? No? Lost him. Anyway, if you think of the pale blue people as being people who are overweight, for example, you'll see that a third of the vitamin D group are overweight compared to a third of the placebo group being overweight. So what we're effectively doing is changing the vitamin D levels, the 25D level in the vitamin D group, making it higher and leaving the placebo group the same. And because we've evened out all those other lifestyle factors, it means that any differences that we see in the two groups we can attribute to the fact that they had differences in their vitamin D levels. So what do the trials tell us about vitamin D and risk of cancer? Well, most of the trials have been done in elderly women, and the reason for that is that they've been focused on vitamin D and bone health. When we pull all those trials together, this is a review from the Cochrane collaboration, which does a lot of this sort of work of reviewing literature and bringing it all together. And what they've concluded is that there's no firm evidence that vitamin D supplementation influences cancer risk in elderly women, but there's not enough information for groups other than elderly women. That vitamin D supplementation decreased cancer mortality, but that the estimates were at risk of quite bad errors in the trials. And then we need more trials on vitamin D supplementation. And I was happy to read that because I'm doing one. So I'm happy to hear that people think it's necessary, although not everybody does. So I am currently conducting a trial called the D-Health trial. We are in the process of recruiting 25,000 Australian adults aged over 60. And we'll be giving half of the people a vitamin D tablet to take once a month and the other half a placebo tablet to take once a month for up to 5 years. And we'll be then following them forward to look at outcomes like cancer, cardiovascular disease, but also just generally how you feel. People say vitamin D makes me feel better. Well, it could just be the placebo effect. So we'll be looking at that as well. So if you happen to know anyone who's aged over 60, please send them to my website because they could join us and help us put vitamin D on trial and find out what it does. But the other thing is that it might not all be vitamin D. The sun might have effects independently of the effect on vitamin D, and trying to disentangle that is very difficult. Robin Lucas, who's here in the audience, is doing a trial at the moment to try and understand that. So if you're under 65 actually, if you're over 60, you need to take part in the D-Health trial. If you're between 60 and 65, you can make a decision. If you're under 60, you can take part in this study, which is called the SED study, which is really trying to understand the difference on our bodies from exposure to the sun versus taking a vitamin D supplement on things like immune function that we know are important for cancer risk, and on metabolic markers like cholesterol and things like that. So this is a really, really important study, recruiting people aged under 65 who've got a current 25D level of between 40 and 60 nanomoles per litre. So that's something that you could also do to help us understand what's going on. Because I can see you all sitting there at the moment going, right, now what are we supposed to do? You've told us the sun is bad, and yes, we know that. You've told us the sun might be good. You've told us it might be via vitamin D, but you've told me about lots of studies that don't confirm that. And right now we're going to go out of here not knowing what on earth we should be doing with all of that information. Yeah, fair enough, I don't know either. So the first thing is all of the information that I've told you a good excuse to sunbathe? Well, no. Doing what that lot are doing on Bondi Beach is a really, really bad idea. That's going to increase risk of melanoma, non-melanoma skin cancers, wrinkles and other things as well, probably. So sunbathing is not a good idea. The current recommendation is that if the UV index is less than 3, that you don't need to worry so much about protecting your skin from the sun. That's possibly needs to be reconsidered. But at the moment in Perth, the UV index doesn't get over 3 often in winter. It's usually 3 or below. So during winter, it's not something that you need to worry so much about. But in summer, for most days of the year, you need to be protecting yourself. But one of the things that we think is really important is we know from data that you're far better off exposing more of your skin for a shorter period of time to make vitamin D. So if you're concerned about your vitamin D level, the thing to do is not to expose your face and hands for a whole heap of time, like half an hour, to try and make vitamin D. It's not a very big surface area, and it's a bit of us where we get most of our skin cancers. What you're actually better off doing, all of you, is spending 2 minutes, 2, not 22, with your tummies and your legs exposed. It's a nice big surface area for making vitamin D. It's a bit of us that doesn't get exposed to the sun very often. So you're far better off actually exposing more skin for a shorter period of time than you are exposing your face and hands, where we get all our skin cancers, for a longer period of time to make vitamin D. So if you're worried about it, that's the way to go about it. So should you take a vitamin D supplement or have a vitamin D test? So looking at whether or not you should have a vitamin D test first, there is not, in my opinion, an epidemic of vitamin D deficiency in Australia, but there is an epidemic of vitamin D testing. We are currently spending about $150 million a year on testing people for vitamin D. We actually don't know what level we need of 25D in our blood. The laboratory test that the labs are using is not very reliable. And more importantly, there's actually not very many people who have got low levels of vitamin D. So this data comes from the latest Australian Health Survey, and it shows the proportion of people that have a level that they have labelled as deficient of less than 50 nanomoles per litre. And actually that's only very, very mildly deficient. And it shows that in Perth, well, in Western Australia, across the whole of the state, for averaged over the whole year, there's only 15% of people who have a level of less than 50. 85% of the population have got an adequate level of vitamin D if we use a cutoff of 50. In fact, the level that we know really does cause harm is a level of less than 30, and there's only 6% of the Australian population across the whole country that have a level of less than 30. So really, actually, this supposed epidemic of vitamin D deficiency that we have is not real. So I would argue that you shouldn't have a vitamin D test unless you have clinical indications for that. The GPs are probably testing too many people, given that 75% of us have got a level over 50 nanomoles per litre. They're hunting for the wrong people, and then they need to target their testing much more carefully. And that is supported by a draft report that's just come out from the United States Preventive Services Task Force, where they say there is not sufficient evidence to suggest that treating vitamin D levels that are only found to be low through a random screening test, there's no evidence to suggest that that's beneficial. So my GP offers to give me a vitamin D test, and I say, no, please don't spend the government's money on testing me for vitamin D. Instead, if I'm someone who gets absolutely no sun exposure, the current Australian guidelines are that you should take 400 international units of vitamin D supplement if you're aged under 70 and 600 if you're aged over 70, if you really get no sun exposure. So we tell people entering the vitamin D trial, we'd like you to restrict your supplementation to 500 international units a day, and that's enough to prevent people from being deficient. So I hope that I've told you all the things that we don't know. I hope that I've left you with a couple of things that you can take away as to what you should do with respect to sun exposure and vitamin D supplementation, but certainly there's going to be a long way to go, and that these messages may change in the future. Just like to acknowledge that the NHMRC supported all of the work, my own work that I showed you about today, the case control studies, and they also support my salary. Lots of collaborators have worked on some of the studies that I've shown you, and obviously all of this work is only possible because people in the general population take part in our research studies. Thanks very much.
Hello, Rachel. You won't be surprised to learn I'm expecting lots of questions. It's always the issue as to who asks the first question, but clearly what Rachel's done has done a fabulous job in walking us through the many complexities of lots of things we don't know, but probed, Rachel can give you a very clear, I think, and very well thought out answer to the questions that you might have. She might not have a definitive one though, because the answer is there's still a whole lot of research that needs to be done. So we'd like to keep the questions on record as well. We're recording this for people who can't make it in the room. Didn't we tell you that? Well, we better get you to sign the permission slip later on, so that people can hear the lecture online. There's a lady in the middle. So if you could wait for the work, but you'll have to wait for the microphone because people who are listening online...
Hello, that was wonderful.
Great,
thank you very much, Rachel. I just wondered about the UV effects on your eyes.
Yes, that's a very good question, and that's why the sun protection message got modified to slip, slop, slap and wrap, for wrap on sunglasses. Or what was the other one? Slip, slop, slap, wrap, slide. Anyway.
Seek in the slide is seek as the shade.
Yeah. So, yes, we know that ultraviolet radiation does cause cataract and pterygia, and that when we're out in the sun, we need to routinely be wearing sunglasses, basically, particularly children. So if you're a school teacher, encouraging children. It's something kids don't do. It's really interesting that we really, as adults, we start to wear sunglasses all the time, but kids tend not to wear sunglasses. So, yes, the UV does have an effect on our eyes, and it's something we need to be aware of.
It's sad, actually, that kids in schools, and I've been teaching a long time, have, that they're told to wear a hat and whatever, but there's nothing about sunglasses that has not got through.
Yeah, there was a thought at a school in Queensland a while ago that they were going to keep a sort of pool of sunglasses for kids to throw on, and I'm not sure that it ever actually happened. I mean, there's certainly been some awareness, and Terry, you can probably talk about whether or not that's been happening in Western Australia, but it's a bit of it doesn't happen.
Big
Yeah.
Big jump, a whole range of fronts.
Yeah.
I can talk about that in a moment, but I'll ask other questions. Gentleman down here, and there's another lady at the back.
A very interesting talk, Rachel. About 8 years ago, I took part in the vitamin D study for the University of Utah, and I was one of the subjects. And the follow-up for that was the recommended level was much higher than 30 nanomoles. And they recommended supplementation at around 2,000 international units a day, which is again much higher than what you recommend. And what are your thoughts on that? But as just a throw-in, they mentioned the occupational groups, and this was in the US, mind you. The occupational groups with the lowest levels of vitamin D, one of them was Australian lifesavers. You'd think they spend a whole working day out in the sun, but they're so covered up they're actually very, very low in vitamin D. So that's just an interesting add-in.
Can I just hang on to the microphone for a minute, because I just want to ask you, what was the outcome in the trial that you took part in? What was the health outcome that they were measuring that made them decide that you needed to take 2,000 IU a day?
At the time, they noticed that as you say, in latitude, they're looking at multiple sclerosis.
MS.
And the higher the latitude, the greater the incidence of MS.
Yep.
Okay.
So multiple, I didn't mention MS because I was specifically focusing on cancer here, but vitamin D and the sun, possibly independently of vitamin D, probably have extremely important effects on the autoimmune system, including the bit of the immune system that causes autoimmune disease like MS. And so there's a study going on at the moment that Robin's involved in, actually, where they're giving 10,000 international units a day. But this is to people who've had a first demyelinating event, so the first event at very early onset MS. Not everyone who has one of those events goes on to get MS. So what they're doing is essentially saying, well, if we give people an enormous dose of vitamin D, can we stop people going on to get frank MS? But that's a really clinical question. These are people who are patients at this point in time, and it's actually trying to really dampen down the immune system. So I think for people who are at high risk, yes, potentially a high-level supplement is a good idea, but we need more evidence about that. But for people who are at not high risk of one of those diseases, in fact, I was at a conference in London, a specific vitamin D conference in London in April, and I saw study after study after study that came up and showed high risks of all sorts of different diseases with a 25D level of less than 30 nanomoles per litre, and then it just plateaued out beyond that for almost every disease outcome. So I think that at less than 30, it's bad, but beyond that, we're seeing more and more to suggest that these promoting higher levels of 75, 100 or even higher, there's just not evidence to support that, in my opinion, but there are people who disagree with me.
Thank you, Rachel. Why do you think GPs are ordering so many tests for vitamin D?
I'd love to know, actually. I think that general practice is very difficult. You're sort of damned if you do and damned if you don't in some ways. A lot of GPs, so there's recommendations about who GPs should test. They're told that they should be testing people who are very dark-skinned, who don't go outside, people who are stuck in nursing homes. But you talk to GPs who say, well, yes, but I tested a patient last week who didn't meet any of those criteria and they had vitamin D deficiency. And it's one of those things where they've only got to see one and they go, right then, I need to now test everybody because I found one. GPs also have got in their heads that we need to be aiming for a level of 75 or 100. And it's because of some early work for some very, very vocal vitamin D advocates who were almost accusing SunSmart of trying to kill people with their message to stay out of the sun. And there was an awful lot of media around that, and GPs just don't have time to read the scientific evidence as it accumulates, and they're as influenced by the popular media to a certain extent as the rest of us are. So I think that there's a bit of a worry about being sued if they miss somebody. But I think it's shifting. The government is trying to stop it, actually. They're really encouraging GPs to be far more selective in who they test.
So I can just comment on maybe one other aspect to that, which is that naturopaths, obviously jump on things early when the evidence is still mixed. And in 2012, the regulations for naturopaths changed and they can't order the tests themselves anymore. They have to refer their clients back to their GPs. So that might also be part of the increase in GPs ordering vitamin D testing.
Yeah.
Because the patients are asking for it based on other advice.
Well, that's the other thing. Patients are asking for it. Yeah.
I like the way you're making Melissa move around.
Yeah, we know.
Somebody up in the top right corner.
Movement's much more important than vitamin D, probably, so you're doing a good job making her move.
Sorry, I was just plucking up courage, otherwise I would have gone sooner. I'm actually a phys ed teacher, so I was very interested in your slide that you indicated that the advertising is having an effect on younger people, but I'm just wondering, is also the fact that perhaps many of those children now are not outdoors because they're also involved in looking at computers and computer games, that they are not being exposed as much to the sun.
Yeah, for sure, that will be some of it. We know that window in childhood where kids are still pretty active in primary school and prior to primary school, not so much screen time. The screen time is, I know it's kicking in earlier now, but it's really adolescence where that's taking off. And we're seeing this drop in rates of skin cancer in people who probably have been protected as young children. So, yeah, it's very difficult. We were talking about that in a meeting earlier, actually, that it's difficult to disentangle what's going on with vitamin D trends and skin cancer trends and all that sort of stuff, and how much of it is due to the protection messages, etc., and how much of it is due to the fact that we all now sit in front of computers, we all have laptops in our bedrooms and all that sort of stuff. And to be honest, that sort of behaviour, the one single thing that we can probably do to maintain our health throughout our lifespan is to move. So far more, we get hung up on wanting a magic pill, and vitamin D might be the magic pill, but actually we need to eat well and move is the key message. And if you're moving, you're probably moving outside and getting a bit of vitamin D happening at the same time. So, yeah.
Thank you. How long does it take for a skin cancer to develop after you've been sunburned?
Yeah, good question. For melanoma, and probably for basal cell carcinoma as well, there does seem to be, for at least some melanomas, a critical period in childhood, which suggests a long time. So probably what happens is that the cells get those first mutations in childhood, and then those mutations accumulate over time to the point where the cell loses control of itself and starts to divide uncontrollably. So actually quite a long time. Although the time from when that last mutation happens, which might be the sunburn that you get going to the beach as an adult, and the development of melanoma, be quite short. What we know for squamous cell carcinoma, which is the second most common type of skin cancer, that using sunscreen in adulthood reduces your risk of getting squamous cell carcinoma. So I did my PhD on a study where we randomised... So the same sort of trial, we gave half of the people sunscreen and told them they had to put it on their face and hands every day, irrespective of what the weather was or whether or not they were planning on being outside. They just had to put it on every day. And the other half, ethically, we couldn't give them a placebo sunscreen, so we told them they could do whatever they liked, which was generally not very much. This was a population of adults aged 25 to 65 at the time of recruitment. We gave them the sunscreen for 5 years, and at the end of that 5-year period, the risk of squamous cell carcinoma in the sunscreen group, the daily sunscreen group, was 40% lower than in the other group. And also, as you get older, we all accumulate sunspots, solar keratoses. The rate of accumulation was much lower in the sunscreen group as well. So that suggests that certainly for SCC, fairly short time span that we can affect our risk.
Thank you, Rachel. I thought it was a great talk.
Thank you.
Probably really ignorant questions. First of all, you don't get vitamin D if the sun's coming through glass?
No. UVB is blocked predominantly by pretty completely blocked by glass, and we need UVB to make vitamin D.
Yeah. And the other question is the dose of vitamin. Should people aim to get out in the sun every day, or can they think, I'll get plenty in the summer, so I won't worry too much when it's a windy day or cold? That's what I'm wondering.
Yeah, so vitamin D has what we call a long half-life. So that circulating marker, 25D, has a long half-life, which means that it stays in your blood for quite a long time, sort of weeks. So the Australian recommendations from various societies in Australia suggest that a level of 50 nanomoles per litre is what we need, but in fact aiming for a bit higher than that at the end of summer is a good idea to see you through at least the first month and a half or so into winter. So I don't get any sun exposure during the week because I spend my life in my office, but I get reasonable sun exposure on the weekend, and I haven't had my vitamin D level tested because I refuse, but that weekend sun exposure should be enough to see me through the week. So you really don't need it every day, so long as you've exposed enough skin.
I think that's probably
I'm off the hook.
exhausted the questions. Well done. Before I ask you to thank Rachel for what I think was an outstanding talk and very clear and thorough answers to a whole bunch of challenging questions, a couple of things I wanted to mention. One is the evaluation forms you've all been given when you came in. As I've said, we've been running this for 20 years and we genuinely do read every single one.